that, it's my pleasure to introduce our speakers today, Andrea and Marlee. So Andrea is a registered dietitian and professional public speaker specializing in evidence-based knowledge translation with a food-first approach. With a passion for media and speaking, she works alongside educational organizations and companies to educate on digestive health, probiotics, and how to make nutrition science easy to digest. Recognized internationally for her work with the public and nutrition professionals, Andrea loves to create excitement around nutrition science in a way that is meaningful to everyday life. Many times she has had colleagues say that they often don't feel confident in interpreting research and appreciate her approach to break it down in a way that is relevant for their practice. Andrea leverages a strong social media following with an extremely engaged audience to create excitement around science communication and nutrition. And Marlee is also a registered dietitian who specializes in digestive disorders, including IBS, IBD, fatty liver disease, SIBO, and much more. Marlee is the team lead for Ignite Nutrition, one of Canada's top digestive health nutrition practices. With her specialized knowledge in GI health, she also helps train and support other dietitians to help them work with those who have unique and complex food intolerances and GI disorders. In 2019, Marlee also wrote a cookbook called Insulin Resistance Diet for Beginners, which showcases her other great passion, women's health and PCOS management. And with that, I pass it over to you both.
Thank you so much for having us today. We look forward to presenting on when it isn't IBS, because I think a lot of dietitians have a good foundational knowledge when it comes to irritable bowel syndrome. Where I see dietitians struggle is when these other symptoms pop up along the way that lead them to believe that maybe something else could be going on. So we're going to dive into navigating those differential diagnoses, how you can support your patients, advocate for them, and the nutrition management associated with some of the most common ones we see in practice. If you have any questions, you can just pop them in the chat and we will save them till the end. Next slide.
Oh, sorry. There we go.
Well, Jocelyn gave us an excellent introduction. If you don't know Marlee and I from the work that we do, we've actually recently launched an online school where dietitians can go to complete continuing education, and that's called Gut Ed. And so if you're looking to download the slides from this presentation and see all the references, you can head over to gut-ed.com and you can sign up for our Gut Ed guidebook. The slides and access to the replay, which is hosted on the Fladzyme website, can be all accessed there. We have a ton of free and paid resources for dietitians to enhance their gastrointestinal nutrition knowledge. Next slide. Okay, so there are a lot of differential diagnoses when it comes to irritable bowel syndrome. We're going to jump into when IBS might not be the best fit, and then talk about some of the common ones, including bile acid diarrhea, exocrine pancreatic insufficiency, microscopic colitis, small intestinal bacterial overgrowth, chronic constipation, and then important clues with each of those diagnoses, the treatment, and the role of nutrition in each. We want you to walk away with some really practical knowledge you can implement into practice right after this webinar. Next slide. Okay, so when is IBS not the best fit? This is a tricky topic because there are several things that might lead you to believe that something else can be going on. I find, especially in Canada, dietitians get more time with patients than gastroenterologists. So we play an important role in advocating for those patients for further workup when they've come to us with a diagnosis of IBS, but we don't really see it being the best fit based on the symptoms they're telling us. In addition, a lot of times patients aren't very comfortable talking about their bowels. They feel rushed in appointments. They don't know what's relevant versus not when it comes to meeting with their gastroenterologist. So we can really suss that out for them in our assessment, and through intervention and appointments, we can kind of tease out what's left and if it is really IBS or if we should be advocating for further workup. Of course, dietitians don't diagnose, but we play that really important integral role in that communication with the medical team. So some odd symptoms to watch for include blood or mucus in the stool, significant nutrient deficiencies or weight loss. Marlee and I both would say that a lot of our patients are trying to lose weight. I'd say on 95% of our intake forms, regardless of what they're coming to see us for, weight loss is listed as a goal. So a lot of times people think that they're actively trying to lose weight. And then when the weight loss starts happening all of a sudden, they don't associate that with an odd symptom. So that's something to watch out for. If a person doesn't have significant abdominal pain, we know pain is the hallmark of irritable bowel syndrome, in addition to some of those bowel changes. If they're experiencing extraintestinal symptoms, so a lot of times we see things like brain fog, joint pain, rashes kind of get dismissed, but they can also be clues as to other things going on. When a person is non-responsive to the low FODMAP diet, so while FODMAPs aren't the only potential food triggers in irritable bowel syndrome, we would expect to see relief from reducing intake of high FODMAP foods. And if we're not seeing that, and if they're being, compliant with the diet, what else could be going on? And the third one is not much additional investigation. A lot of patients don't actually meet the criteria to see a gastroenterologist a lot of times based on what they're telling their family doctors, or are managed by their family doctors as opposed to gastroenterologists. So a lot of times they don't have that additional investigation of colonoscopies, blood work, etc. So that's kind of a red flag to us to consider what else might need to be done to complete their workup. All right.
Okay, so we're going to dive into some of these conditions, starting with bile acid diarrhea. This is a very common cause of chronic diarrhea, so we thought it would be good to start here. So essentially what's happening with bile acid diarrhea is that the person is malabsorbing or overproducing bile acids. So little biology lesson here or reminder for some of you. Bile acids are produced in the liver and then they get stored in the gallbladder. So when we eat food, those bile acids get released into the small intestine from the gallbladder. And the role here is to help with absorption of fat. So after that job is done, the bile acids get absorbed in the terminal ileum, which is the very last sort of portion of the small intestine. And then they go back to the gallbladder. It's kind of like a cool little recycling program for bile acids. So in a normal digestive process, very few of these bile acids will continue on to the colon, but this is where bile acid diarrhea or bile acid malabsorption comes into play. So they're either being malabsorbed in the terminal ileum or the body is producing more bile acids than what the ileum can reabsorb in a certain period of time. So a good portion of these bile acids are making their way into the colon, where they essentially irritate the lining of the colon, and they're also very osmotic. So this just means that they're going to attract a lot of water, which is really that cause of loose and watery, very secretory stools. Okay, so in terms of pathogenesis, let's chat some statistics here. So up to 25 to 33% of chronic diarrhea may be caused by undiagnosed bile acid malabsorption. And interestingly, this statistic is actually probably higher, about 50% is the estimated amount for folks who meet the diagnostic criteria for IBS-D. So as you can see, there's a lot of overlap between these two conditions, bile acid diarrhea and IBS-D. And while while IBS is typically characterized by some abdominal pain, diarrhea can also precipitate abdominal pain. So a lot of these folks with bile acid diarrhea will also have that pain symptom as well. So it's not cut and dry. It's not easy to say hey, they don't have pain, so it can't be IBS, or they do have pain, so it has to be IBS. They overlap so much. The average time to diagnosis for this condition is quite long, about 5 years. Because of that and all the additional testing and other things that are being ruled out, it can have a significant cost for the healthcare system. So we want to be learning how to catch this a little earlier if we can, and helping doctors catch this if we feel like it's taking place. So there are 3 subtypes. Structural is the first. So bile acid reabsorption is impaired because of structural changes in the small bowel. So essentially, that terminal ileum might be impaired in some way. So it could be celiac disease, where the villi are damaged, or it could be after someone has surgery. Those are just 2 examples. The second type is idiopathic. So structurally, everything looks normal. No major issues can be seen, but it may be due to like an overproduction of bile acids where we just can't keep up with the absorption that needs to happen. And then the third is secondary to other conditions. So this is where there's an impaired reabsorption of bile acids because of something else. SIBO is one. We will definitely talk about SIBO more later, as well as things like gallbladder surgery, chemotherapy. With SIBO in particular, what's so interesting is when we have extra bacteria in the small intestine, they will actually deconjugate bile acids, which just makes them unabsorbable in the terminal ileum. So that's why they end up moving through into the colon, causing that diarrhea. Whoops. Okay, so in terms of clues to look for in IBS patients when it comes to this condition, diarrhea would be ongoing even when following the low FODMAP diet. So a lot of these folks have already attempted a low FODMAP diet or a modified version of that, and they might see some improvement in other symptoms, like maybe the bloating has gotten better or the pain has reduced, but that diarrhea is persisting. So that can be a clue. These patients really experience multiple loose, very watery, secretory stools, often very urgent. That seems to be a pretty classic presentation, lots of urgency, sometimes to the point of having fecal incontinence or fecal leakage. So definitely ask questions about that. It can be a little uncomfortable, of course, to ask questions about that, but it's really important to know. Another really good clue is when we ask about the patient's fat intake and how this affects their symptoms. So, for example, often people will say, restaurant meals never agree with me. I always have really significant diarrhea after going out to eat. So when we prompt further, we often learn, they're having a really rich pasta or lots of cheese, or fast food. So those can be clues about fat intake, and therefore might point to bile acid diarrhea. The appearance, excuse me, the appearance of the stool can also give some clues. So clients might see oiliness in their stool or visible mucus or a really pale kind of clay-colored stool. However, this isn't a sure thing when it comes to bile acid diarrhea. So don't write off this condition if they don't see that oiliness, because as long as it's very watery, that could still point to what bile acid diarrhea. And unfortunately, one thing that does get missed more often than not, more often than we'd like at least, is their history of gallbladder surgery. So often when people have had their gallbladder out, they struggle to regulate those bile acids because the liver is now taking over the role of releasing bile acids into the small intestine. So it's not always great at getting those ratios correct. Often this is worse in the first year after gallbladder surgery and it will go away on its own, but not always. So definitely probe about their surgery and what they've experienced if they had a cholecystectomy. Did I go too far? There we go. Okay. So gold standard for diagnosis is, oh, I did go too far. There we go. For diagnosis is something called a CCAT test. And this basically measures the retention and reabsorption of bile acids. Unfortunately, it's not widely available in all centers. It's not something we have in our area, unfortunately. So it's more popular in research settings ultimately. So instead, what we see used most often is treating suspected bile acid diarrhea and monitoring the outcome. So essentially, if the response is good to medication, which is called bile acid sequestrants, then diagnosis is confirmed at that point. But there is some flaws in this approach. If the bile acid diarrhea is actually being driven by an underlying factor, for instance, SIBO, then this isn't
Jocelyn, can you still hear Marlee?
Oh, go ahead.
Sorry, you cut out for a second. Keep going.
Oh, hopefully you didn't lose too much of me, but those different medications are cholestyramine, cholestyramine, and cholesevalem. Cholestyramine is a powder. Typically, that's how the format we have it in Canada mainly. But you can get some of these other ones in tablet form. We just don't have as much access to that in our area, unfortunately. And interestingly, soluble fiber supplements can also have a mild bile acid binding effect. So things like psyllium, for instance, if people seem to do quite well with that, that can also be a bit of a clue that, maybe there's a bit of bile acid diarrhea happening, but likely those are not going to be strong enough on their own. Okay. So of course, we've chatted about the fact that medication management plays a really big role here. However, we do see a lot of compliance challenges with these medications, mainly because of poor taste and texture. They're not great. So this type of treatment requires a lot of effort and also proper timing. So they're supposed to be mixed into a liquid, and taken right before a consumption of a meal. We find a lot of our patients do better when they can mix it into something with a flavor, like yogurt or orange juice. And like I said, in some places, pill form is readily available, which is much, much easier to take. Additionally, small frequent meals can be really helpful. When we have smaller volumes of food, we're going to release less bile into our gut all at once, and that can help to manage some of the challenges with reabsorption in the ileum. So that's a really important step for folks most of the time. And there is some evidence that also supports a lower fat diet, which of course makes sense here, but we have to be, kind of careful with that subject, especially if people are already really restricted, or if they have challenges with their food relationship. We don't want to go too low on fat if we can help it. And because of those challenges, we want to ensure that there's also adequate intake of fat-soluble vitamins. Sometimes we see some challenges with deficiencies there. And of course, a lot of these folks have already attempted a low FODMAP diet and they've noticed some benefit. So if that's the case, it may be because FODMAPs also have an osmotic effect and they're pulling more water into the colon as well. So sometimes people will sort of attempt a combined approach, a little bit of FODMAP reduction, as well as managing with proper medication, small frequent meals. But that's something that ultimately you have to weigh with each individual, of course. And then fiber supplements, as I mentioned, can help as well with both stool consistency in general and also with that bile acid binding effect. All right. The next thing we're going to chat about is EPI, exocrine pancreatic insufficiency. For convenience, I'll call it EPI. It's a bit of a mouthful. So the reason we kind of flowed into this one is because it's also a pretty, I wouldn't say as common, but it's a cause of chronic diarrhea as well. So there are various causes of this, and the prevalence sort of varies depending on the cause. So the estimated statistic here is anywhere from 1 to 6% of patients diagnosed with IBS-D could have EPI. But it's hard to know for sure. So while it's not uncommon, I would say diagnosis is not super common with this. It could be something we're missing more often than not. So what's happening here is that basically there's an underproduction of digestive enzymes in the pancreas. So this leads to sort of a chain reaction of issues, poor digestion, malabsorption, and generally diarrhea as a result. So some of those causes that I mentioned include pancreatic surgery, cystic fibrosis, pancreas divisum. Essentially, this is like an anatomy issue with the pancreas. Pancreatic duct obstruction, cancer of the pancreas, diabetes, IBD, and Sjogren's syndrome. I'm sure there are others, but those are kind of the mainstay causes. And symptoms, as I mentioned, include diarrhea, especially that very malabsorptive diarrhea due to inadequate enzymes. And a lot of patients also have significant bloating, significant abdominal pain. We do see that sometimes weight loss is involved, but not always. It sort of depends on the severity of their condition. And a lot of times we assume that these folks are seeing fecal fat because of poor absorption, but it can be quite difficult to see. So basically, evidence says that they need about 30 to 40 grams per day to actually have visible fat in the feces. So that's where that more detailed testing and diagnosis is really important. And sometimes, actually very often, the stools are floating, but not always. So again, we don't want to just assume. I will say we don't actually see EPI a ton in our private practice because in the setting we work in, I think it's just a very specific patient population. With our clientele, we don't see as many males. This is more present in males generally. We also don't see a ton of like alcohol abuse, which is another driver of this in a lot of cases. So I wouldn't say it's our biggest thing, but it's going to be way different in other practice settings. Okay, so very similar to bile acid diarrhea in many, many ways. So much like bile acid diarrhea, we see symptoms ongoing even when following the low FODMAP diet. The most predominant issues in these patients tends to be that very loose, watery stool. Again, lots and lots of urgency. Sometimes we see that visible fat, but not always. Stools can float, like I mentioned, sometimes not always, again. And for this condition, we do see that unexplained weight loss quite a bit more. So we definitely want to be probing about those sorts of symptoms. It's definitely a red flag for this, probably even more so than something like bile acid diarrhea. And of course, we also want to be asking about those other potential causes. So we want to be probing about family history, previous experience with acute or chronic pancreatitis, alcohol consumption habits, all of those sorts of things. And lastly, see if they've had recent blood work or if we could receive new blood work. Looking at some of those fat-soluble vitamins in particular, as deficiencies are more common in EPI. So it sounds so complex, and it is, but at the same time, the diagnosis is actually a very simple stool test. So we're measuring fecal elastase 1, and anything above 200 is normal. 100 to 200 could indicate moderate EPI, and less than 100 is generally associated with more severe EPI. So, of course, with medical management, it's first important to manage that underlying cause, which will require some additional investigation typically to really suss that out. Additionally, we want to make sure that any malnutrition or nutrient deficiencies are being addressed, in particular, those fat-soluble vitamins. And in terms of nutrition management, similar to what we spoke about before, small frequent meals is something we typically want to implement. Smaller volumes means that, any enzymes we are able to produce on our own are going to hopefully, deal with those smaller volumes a little bit better. But the kind of mainstay treatment is using pancreatic enzyme replacement therapy, or PERT. So these were originally based on cystic fibrosis and pancreatic cancer, so pretty severe forms of EPI. So some patients may require less than what these practice guidelines are suggesting. So there's a bit of trial and error associated with figuring out what's best. But in general, the guidelines suggest 25,000 to 75,000 lipase units with meals and 10,000 to 25,000 lipase units with snacks. Another measurement we see is 500 to 4,000 lipase units per gram of fat. That's a little more, in the weeds than we typically like to go, because we don't want folks to feel like they have to obsessively measure every gram of fat necessarily. Administration, again, we want to make sure people are taking these things correctly. So half before eating and half in the middle of the meal often works for folks, but in a lot of cases that are a little bit more mild, even just taking it beforehand can be enough. So it's, again, a bit of trial and error to figure out what's going to work best for the client. And I do want to mention that when we have pancreatic dysfunction like this, it's not just lipase that we need. It is things to help us digest carbs and protein as well. And these PERT products do have those, but we base our dose on lipase units because that's sort of the biggest factor, if you will. Okay. All right, back to Andrea.
Okay, so many good questions in the chat. We've addressed several, but some of them I'm saving for more discussion at the end. So microscopic colitis. Microscopic colitis is a form of inflammatory bowel disease. It does involve inflammation of the colon due to an inappropriate or immune response in the colon. And so this inappropriate immune response recruits either lymphocytes or collagen, and that's how we differentiate the two types, lymphocytic colitis versus collagenous colitis. And the buildup of these two types, collagen or lymphocytes, influences the ability for the colon to reabsorb fluid and electrolytes, resulting in symptoms. Next slide. So with microscopic colitis, we often ask ourselves this in clinic: is it becoming more common, or are we getting better at diagnosing it? I'd assume it's a bit of both in relation to risk factors.
You cut out there for a second, but I think we're okay now.
So I think it's a little bit of both. We're getting better at diagnosing, rates could be increasing. I think this is in part due to that aging population, the risk factor of older age, that 45 to 60-year-old individual. We're getting better at diagnosing it. Some of the medications that can influence or are associated risk factors are becoming more common. And so one pooled analysis found that about 2.5% of patients with IBS-D actually had microscopic colitis, which is a fairly substantial amount. In our practice, maybe Marlee can confirm this, but we do find the risk factors to align with the patients that do get diagnosed. So older age, it's more common in females, especially if they're in perimenopause, menopause, or postmenopause, if they've been on hormone replacement therapy, or associated with birth control use. So most of my patients have been that female in menopause or postmenopause, and then possible history of use with hormone replacement therapy. We do know smoking history is associated with higher risk, concomitant autoimmune diseases, post-infection is a possible cause. Estrogen, they believe, probably influences the development of microscopic colitis. Drugs, like we mentioned, and then of course, genetics, possible gut microbiota. A lot of my patients describe this as sudden onset, like one day they just had a major change in their bowels, which I think is one of those things, when we do assessment and ask a patient, how did this onset? When did this onset? What was it like for you? So that we can determine, was this a gradual change over time? Of course, with irritable bowel syndrome, post-infectious, irritable bowel syndrome can have that sudden onset. But I find it's kind of a clue to something changing in their bowels that is worth a deeper look. Next slide. In terms of symptoms for microscopic colitis, it does present somewhat similarly to bile acid diarrhea, where there are multiple watery stools a day. I find urgency and fecal incontinence to be more present, although they can be present in both. It seems to be more present in microscopic colitis. Nocturnal diarrhea is common, abdominal pain. A lot of my patients report feeling like inflamed. I know sometimes with IBS-D, diarrhea, patients report that kind of inflammatory feeling, but I hear it more when I'm asking a patient about how they describe their symptoms in microscopic colitis. They often report fatigue, brain fog, low energy, due to the malabsorptive nature of microscopic colitis. And then a big one that we wouldn't typically see with IBS would be weight loss. Not all of my patients have experienced weight loss, especially given the patient population does tend to be female, does tend to be as they're going through menopause. So their weight kind of can be fluctuating higher, lower, but a handful of patients that I've seen and Marlee have seen, weight loss is definitely a predominant symptom. So these patients, a little bit of a differentiator would be that sudden onset, significant diarrhea, like way more than what you would expect with IBS-D typically, and then female in perimenopause or postmenopause. Next slide. Okay, so in terms of diagnosis, like I mentioned, I feel like here in Canada anyways, where we practice, we're seeing more patients receive biopsies during a colonoscopy to rule in or out microscopic colitis. So the tissues can appear normal upon viewing with the eye, and they need pathology to really see if there's the buildup of the lymphocytes or the collagen. We've had quite a few handful of patients where this has been missed because they haven't had a scope or they haven't had biopsies on a colonoscopy. And they might have been part of their diagnostic workup for IBS, but they were missing the biopsy portion. And when the diarrhea was severe enough and we went back and advocated for a second look, microscopic colitis came up. In terms of therapy for microscopic colitis, medication management is the core because it is an autoimmune condition for which inflammation is the primary driver. So budesonide, which is a corticosteroid, tends to be first-line approach, though you will see some physicians use bismuth subsalicylate or Pepto-Bismol. There's more evidence for budesonide, but I have had patients do well with the Pepto-Bismol. Consideration is cost. People typically pay out of pocket for Pepto-Bismol, and they do need to consume a lot of it to meet what the one study looked at. So budesonide is often, more efficacious, more evidence-based, and if it's covered by benefits, can be helpful. Other treatments include other types of steroids, biologics, and then loperamide as an adjunct or codeine as an adjunct to manage diarrhea until improvement is seen. So I find a lot of patients are nervous to use loperamide, especially if they're being prescribed other drugs. But I think, asking the physician to discuss appropriate use of loperamide or explaining to a patient how loperamide works so that they can leave the house without needing to use the bathroom or having an incontinence episode can be really helpful. So advocating for proper use of medications in this condition, I think, is really important. Next slide. In terms of medical nutrition therapy, I have yet to see a research article. Maybe somebody here has, but we've yet to see a research article come out around medical nutrition therapy in microscopic colitis. So we're going to speak from a little bit of experience and a little bit of common sense in diarrhea management. Microscopic colitis tends to be relapsing in nature, so they might need recurrent medication management and dietary changes to help manage symptoms. A lot of my patients will be on a higher dose of budesonide, titrate down, maybe be off of it for a period of time, and maybe have to titrate back up, or may need a low dose long term. There is no microscopic colitis diet. However, given how patients have presented to our clinic, typically with IBSD, we try something like a low FODMAP diet and we're still seeing, excessive amounts of diarrhea. So we advocate for a scope and microscopic colitis is found. We do find that a low FODMAP diet has been shown to be helpful in our patients, likely due to the ability to help manage some of the fluids in the lumen of the colon that can't be reabsorbed due to the osmotic nature of FODMAPs and the fermentability of those FODMAPs. So we do find that as a helpful adjunct. Sometimes we do more of like a gentle FODMAP approach, so it's not so restrictive. Fiber supplements can help to improve stool consistency, urgency, and incontinence by providing a bit of bulk to stool, helping to reabsorb some of the water the colon isn't able to. And like Marlee mentioned, they act as weak bile acid binders, which brings me to my next interesting fact is that bile acid malabsorption is actually present in about 45% of patients with microscopic colitis. So the overlap is substantial, and advocating for a trial of bile acid sequestrants when a person has persistent osmotic diarrhea can be helpful. So where I found this is helpful is, let's say you have a patient with microscopic colitis, they're on medication management like budesonide, and they've been given instructions to titrate down, but every time they titrate down, they're not able to really, they have to go back up, or they're having to be extremely restrictive with their diet. I think those are excellent candidates to advocate for considering bile acid malabsorption to see, can we reduce the meds? Can we liberalize the diet? What other factors are contributing to ongoing symptoms? So that's typically where we bring that piece of things in. Other things we found are helpful, reducing caffeine, alcohol, osmotic carbohydrates. So we've talked about that from a FODMAP perspective. Patients that lactose malabsorb, reduce lactose containing foods, reduce spicy foods. A lot of our patients report, that seems to be a trigger, as well as high fat or greasy foods. Small frequent meals seem to be better tolerated in our practice. And then We focus on increasing soluble fiber and viscous fiber, again, to help compensate for what the colon is not doing adequately.
Okay, I'm realizing how much I've talked. So I'm going to try to keep this succinct, but I could talk forever about small intestinal bacterial overgrowth or SIBO. But we'll go through some of the basics for sure. So SIBO is dislocation of colonic bacteria into the small bowel. So it's a dysbiosis. It's not considered an infection necessarily. So, in a typical kind of healthy gut, the small intestine is considered to be quite sterile, unlike the colon, which is, full of bacteria. That's where our gut microbiome lives. So it's odd to see a lot of bacteria in the small bowel. In terms of definition, SIBO is defined as a bacterial population greater than 10 to the power of 5 to 10 to the power of 6 organisms per milliliter. Ooh, that's a mouthful. And this can be found on small bowel aspiration tests. We don't see this done very often typically, but that would be considered an overgrowth. And typically there's a lot of gram-negative organisms. So things like Klebsiella, Escherichia genera, that's a tough one, and methanogen, so methane-producing bacteria. So SIBO symptoms, again, there's a lot of those IBS type symptoms, which is the whole point of this talk today. But I've heard a lot of my colleagues describe it as IBS on steroids, and I think that is a very accurate description. It's very, very severe IBS type symptoms. In particular, I would say the sort of hallmark symptoms are postprandial fullness, bloating, like quite extreme bloating, and abdominal distension. Often 1 to 2 hours after eating, but a lot of my clients actually describe it as like just persistent bloating and distension. They're waking up bloated, they're going to bed bloated. It's kind of constant for them. Other symptoms, early satiety, nausea, belching and gas, abdominal pain and discomfort. So again, very IBS type symptoms. And often we see some non-digestive symptoms too. So things like confusion, fatigue, brain fog after eating. We can see with SIBO both weight loss and weight gain. There seems to be cases made for both. So it doesn't necessarily go one way or the other. But a lot of folks will say, my body has changed so much, whether it's up or down. Diarrhea and urgency can happen, but so can constipation. And often this does vary a bit depending on what type of SIBO they have, but it's not a sure thing. So it doesn't mean diarrhea is always associated with hydrogen and constipation is always methane. Although those are the more common presentations, we have to be open-minded. And like we said earlier, there's that element of bile acid diarrhea for a lot of folks, especially the more, diarrhea dominant SIBO clients. So some clues to look for. Ultimately, our philosophy is if patients are presenting with IBS and all other potential diagnoses have been ruled out, but they're not responding to really any diet or lifestyle interventions, and they really have that persistent bloating and distension, SIBO should be considered at that point. A lot of times we will have folks who they've done things to resolve their constipation through other interventions. Maybe that's fiber changes, laxatives, hydration, but the bloating is persisting. So that is a really good first step is, if we can get their bowels quite regular, is that helping with the bloating as well? And if it's not, then again, SIBO might be something to consider. And there are some biomarkers that can be a bit of a clue too. So often iron and B12 are low because bacteria will consume those in the small bowel. And interestingly, folate kind of goes the opposite way. So we often see elevated folate because of the way that the bacteria in the small intestine will metabolize folic acid. Just in that little box on the side there, we talk about the rates of SIBO in IBS populations. It appears to be about 30% of the IBS population will test positive for SIBO based on a pooled analysis. But I do want to point out that the average kind of healthy population, about 10% will also test positive for SIBO. So there's definitely more in IBS folks, but we do see it coming up in healthy individuals as well. Okay, diagnosis. So there are a few different ways to diagnose, but the primary way that we see it diagnosed is through hydrogen and methane breath testing. Again, I could spend forever on the details of this, but the basics of what you need to know are there are different types of gases that can indicate SIBO and different types of SIBO. So with hydrogen, or H2 is what we would see it labeled as, a rise in greater than 20 parts per million from baseline to 90 minutes is diagnostic for hydrogen dominant SIBO. So if they have their first breath sample as a 7 and their 90-minute breath sample is 27 or 28 or whatever, then that is indicating that type of SIBO. With methane, it's a little more cut and dry. Anything above 10 at any point during the test is indicating intestinal methanogenic overgrowth or methane type SIBO. I do want to mention that there's another gas, H2S or hydrogen sulfide. We don't currently have widely available testing for this in Canada. It's coming up a bit more in the States for sure. But the proposed diagnosis for this is greater than 6 parts per million of hydrogen sulfide gas on the test. There are 2 different substrates we see used in these tests, both glucose and lactulose, and they each have their pros and cons. Glucose is very specific, but it does get consumed in the bottom part of the gut or the small intestine. So it's hard. We sometimes miss SIBO in that area. And with lactulose, it can speed colonic transit a little bit. So that can sometimes impact testing. But it is going to catch more SIBO in the lower small bowel. And then there's another test called small bowel aspirates, but we don't see this used a ton, at least not in the centers we're working in. If you do have this in your center, that's great. It is considered, more accurate, but we certainly don't see it a lot. Okay, in terms of SIBO treatment, antibiotics is the primary treatment. So most of the literature we have is on hydrogen dominant SIBO, with rifaximin being the primary advised antibiotic. So when it comes to the methane type, IMO, we do have less research, but what we do have also advises using antibiotics, again, primarily rifaximin. In more significant cases of IMO, where methane is greater than 20 parts per million, it may be beneficial to actually have 2 antibiotics. Rifaximin and neomycin is what the literature suggests, but again, it depends what's available. In Canada, we don't have a lot of neomycin available. So the second option is something like metronidazole or another broad spectrum antibiotic. And with the hydrogen sulfide SIBO, rifaximin is also the advised approach right now. We also have the elemental diet. We don't have a lot of high quality studies yet, but they're working on more research here. It does appear to help with eradicating SIBO, but certainly comes with a lot of challenges. And it's important to note that diet alone, except for maybe the elemental diet, we're still learning, doesn't treat SIBO or make bacteria go away. So it's a symptom management tool, but it's not necessarily a treatment approach. So antibiotics are still the kind of gold standard. And then there's some herbal options that do get recommended a lot by alternative health practitioners in particular. And there's one study or trial, I guess, on this, but it was not done very well. So at this point, there's not enough high quality evidence to recommend that. I think I'll skip past some of this stuff just for the sake of time, but this kind of talks about the fact that, reoccurrence is fairly common with SIBO, and these are some of the statistics we're seeing. One big thing here, the final point there, is that SIBO relapses more in folks who have motility issues. So if they're having a hard time having, food and stool move through their system, there's a chance that bacteria will get translocated from the colon into the small intestine. So we just want to address that often through prokinetics. So as dietitians, we can advocate for proper use of those things to prevent reoccurrence of SIBO. The role of diet. So of course, as dietitians, we're playing the role of advocate quite a bit. The ACG clinical guidelines suggest very low evidence for the low FODMAP diet in SIBO. And they actually don't talk about any other diets in the guidelines. So although there are a lot of, proposed diets, there's not a lot of studies on any of them at this point. One study compared the effects of low versus high FODMAP diets on symptom severity, but this actually wasn't a SIBO test. So they did find that hydrogen production was affected by the low FODMAP diet, but again, not a SIBO study necessarily. So again, we want to think of this as a tool for symptom management, not necessarily a treatment strategy. The only thing that seems to be somewhat promising is the elemental diet or exclusive enteral nutrition. And like I said, lots of challenges. They taste awful. And they, folks aren't supposed to be eating any solid foods, which can really impact someone's relationship with food and their body. So not our first recommended approach for sure. So some of those proposed diets, the low FODMAP diet, as I mentioned, seems to be, the least restrictive, believe it or not. And, a lot of us have a lot of experience with the low FODMAP diet. So it's something that we have more confidence guiding our patients through in terms of symptom management with their SIBO. Another fairly good one is the Cedar-Sinai low fermentation diet. So this one is also, not as restrictive as some of the things we see. And they really, I would say it sort of piggybacks off the idea of the low FODMAP diet as well. But the other four listed here are not well researched and much more restrictive generally. But ultimately, our big thing is if patients want to pursue something and you can help them do it in a supported way, and they're very adamant about something, then we're pretty open to anything ultimately, because there's not a lot of evidence here at this point. We just want to make sure our patients are, getting the nutrients they need and having support from a dietitian ultimately. So there's no perfect option at this point. Okay, Andrea.
Sorry, I got sidetracked answering the questions. Okay, chronic constipation. We are running a little behind, so I'm going to kind of whip through this. But I just want to point out that chronic constipation and IBS tend to be what I think of them as a spectrum. So IBS-C, pain is the predominant feature. Chronic constipation, a person can have pain, but it's not necessarily the predominant feature. The reason why I like to bring up chronic constipation apart from IBS-C is because a lot of times if we're able to resolve a person's constipation, they don't necessarily meet the diagnostic criteria for IBS-C anymore because pain is managed or pain wasn't their predominant symptom to begin with. But the consequence of, being diagnosed with IBS-C is a lot of people get the IBS-C diagnosis, get told to follow the low FODMAP diet, and the low FODMAP diet isn't going to fix chronic constipation. Next slide. So in terms of foods to look for in IBS patients, constipation in isolation of other IBS type symptoms, they tend to have loose stools that are rarely present without the use of laxatives. They may struggle with hemorrhoids, reflux, anal fissures related to excessive fecal load and constipation. And then, of course, they don't see that significant improvement from following the low FODMAP diet. So typically with these patients, when somebody is diagnosed with IBS-C, I like to focus on resolving the constipation first, or doing our best to improve the constipation, followed by, okay, what symptoms are left? Is pain still the predominant feature, bloating, gas? Then we can layer on the low FODMAP diet. In terms of the diagnostic criteria for constipation, it's very similar to IBS-C. So they need to have at least 2 of the following: straining for at least 1/4 of the defecations, lumpy or hard stool, Bristol stool scale type 1 and 2 for 1/4 of the defecations, a sense of incomplete evacuation for 1/4 of the defecations, a sensation of anal rectal obstruction or blockage for 1/4 of the defecations, and manual maneuvers to facilitate defecation, including pelvic floor support. So this is positioning. If they require positioning to be able to pass the stool, that's a sign. Less than 3 spontaneous bowel movements per week. So they just need 2 of these to meet the diagnostic criteria. And then from there are additional subtypes a physician can look into. But I have to say, most often, people just get that label of chronic constipation or IBS-C, and the subtypes don't necessarily get worked up, at least here in Alberta. Next slide. In terms of chronic constipation, there can be a lot of underlying drivers. So making sure that we consider those and the management of those before just jumping into IBS-C or chronic constipation is important. Conditions that influence constipation can include hypothyroidism, hormonal changes, medications, including opioids, SSRIs, neurological conditions, connective tissue disorders, and then, the things that we're able to really look at and manage as dietitians are assessing if there's any stress or fear of passing bowel movements, so stool withholding behaviors in particular, whether that's because of public spaces or hemorrhoids, whether diet or lifestyle factors influence their constipation. And then further workup includes things for dysnergic defecation, pelvic floor dysfunction, and motility disorders. In terms of medical nutrition therapy, somebody kind of pointed this out in the Q&A, like, as dietitians, we have all these tools in our toolkit. A lot of them do overlap amongst all of these conditions. So I think that's important to note that, there's so much we can do to help a patient. And then from there, we can work as advocates. And this is true in chronic constipation as well. So typically with constipation, depending on the severity of constipation, I do like to consider how much fecal burden a patient has first, whether it's IBS-C or chronic constipation, and reduce the fecal burden as needed with osmotic laxatives, and then layer on medical nutrition therapy. We don't want to add more, cars to a traffic jam, which we would do with adding fiber when somebody has a significant fecal load. So typically, depending on the severity of their constipation, I would start with osmotic laxatives, reduce fecal burden, and then incorporate medical nutrition therapy like hydration, fiber, boosting low FODMAP fiber just from a bloating gas perspective, and then some basic nutrition strategies, choosing things like prunes, kiwi fruit, or psyllium, those strategies that are evidence-based, kind of the low-hanging fruit to improve laxation. Meal timing and spacing, making sure people aren't skipping meals, really trying to leverage that gastrocolic reflex to stimulate sensation and the need to have a bowel movement. And then making sure people are meeting their nutrition needs, to make sure that they are not under eating, because oftentimes underfueling can be associated with constipation. Next slide. Just a note, we will be staying on a little bit extra. If you guys can say, great. If not, we understand, and the replay will be available. Slides will be available on GutEd. But I'll just keep going because I have the time. And if you know me, you know I can talk forever. So, okay. So in terms of medication management, I think it's important to recognize that diet can only take us so far in constipation management, and medications can be super helpful. So I mentioned osmotic laxatives as a great way to reduce fecal burden. And then dietitians, if they're feeling like, hey, this is chronic constipation, a low FODMAP diet, and a diagnosis of IBS-C doesn't really fit, we can advocate for some of those prescription drugs, including the pro-secretory agents and prokinetics. The stimulant laxatives, I find patients are either really afraid to use them or overuse them. There seems to be no one in the middle. So they can be used occasionally to resolve situational constipation, for example, travel. Because I think a lot of our patients will find that they get, slower during changes to their schedule or travel. Next slide. And I just wanted to bring our attention to a very important subtype of constipation, dysnergic defecation, which is like the actual coordination to facilitate a bowel movement of our muscles, our pelvic floor, our sphincters, is the cause of a significant amount of patients' constipation. So adding fiber and water and dietary strategies isn't necessarily going to help these people adequately to improve their constipation. Yes, it might soften stool. Yes, it might make it easier for them to pass that stool, but a good majority of them need further workup or further management options presented. So straining and complete evacuation. I saw somebody post in the comments, patients reporting like skinny snake-like stools can sometimes be a sign of pelvic floor dysfunction and dysnergic defecation. If you're in a center that has access to balloon expulsion or I can never say it, defecography, or anorectal manometry, that's great. A lot of us don't have access to that. So a pelvic floor physio who's trained in assessing for chronic constipation can also do physical exams to help rule in or rule out the role of pelvic floor, and how the sphincters are coordinating. So consider that in the potential differential diagnoses for IBS-C as well. Next slide. Okay, so to wrap up, I feel like we talked a lot of this throughout each of the differential diagnoses, but really asking our patients the right question is key. Understanding deeply the appearance of the stool, the frequency of stool, the volume of stool can be really helpful. Ruling out fecal incontinence, nocturnal diarrhea, stool withholding. A lot of people don't mention those things unless you ask them. Asking about gas and bloating and pain, how they experience it, what causes it to onset, what relieves it, can help provide clues about these differential diagnoses. And then other workups, so whether they've had other labs, whether they've had an unintentional weight loss, allergy type symptoms, brain fog and fatigue. These capture some of the diagnoses we covered, but there are so many more that we didn't have time to cover today. And here is a list. I'm not going to go into detail, but the slides will be downloadable and you can look into each of them. Okay, so speaking of downloadable slides, we have those slides available for you on gut-ed.com in the Gut Ed Guidebook. Somebody asked where. It's in the IBS section under workshops. So the Gut Ed Guidebook is free. My team at Ignite Nutrition regularly updates it for you on various topics, and we take topic recommendations as well. We just added a section on inflammatory bowel disease. We just added a section on fermented food and the gut microbiota and probiotics. So there's a lot in there on different GI topics to improve your knowledge beyond the slides from this webinar.
Great. Well, thank you both for a fantastic presentation and for staying on a little bit later to answer some of these great questions that we have in the chat. For everyone out there, thank you also for hanging on. We're going to just kind of do what we can to get an assortment of different questions on various topics that seem to be kind of common threads. So I'll start with a couple of these. Here we have a question. What can we do for patients who benefit from bile acid sequestrants and with BAD, but still complain of a tremendous amount of gas? So I'll leave it to you two to battle over this one.
Yeah, so they're getting their results from bile acid sequestrants, but they're still experiencing gas. So this is where I find the low FODMAP diet to be helpful. Reduce those gas-producing foods. Eating behaviors, whether they drink through a straw, whether they're air swallowing, can be helpful. Gas-X can be really helpful. What's the methicone? Is that right?
Simethicone, yeah.
Gas-X can be really helpful, or simethicone can be really helpful in breaking up those bubbles.
Or products like Fodzyme.
Right.
And if they don't want to be strictly low FODMAP, if they know certain foods make them really gassy, then Fodzyme or other, products that are going to help them digest things would be helpful.
Great. Thanks, guys. Here we have another question from Jessica on if you've noticed any difference in the time between eating and onset of symptoms in these different conditions. I know you mentioned that a little bit, but maybe if you could elaborate on that.
Yeah,
for sure. So this is definitely one of those kind of roadmap clues. The onset of symptoms, the timing of those symptoms can be really helpful. With SIBO, I mean, Marlee can speak more to this because it was her section, but the onset of bloating after a meal, like within an hour after a meal, can be a clue that something's getting fermented higher up. But that can also be a clue of, my gosh, the inappropriate movement of the diaphragm, gastric accommodation.
Abdominal phrenic dyssynergia.
Yeah.
It's a tough one to say and spell. But I would say, and with SIBO, like I said, I find like sometimes it's just almost so constant, that bloating. Like I'll often probe, like, are you waking up bloated? And not everyone's going to, but that, significant bloating in particular in the morning and kind of like persisting all day can be a clue for that, for SIBO, I feel. Yeah.
Could be a webinar in itself.
Oh, for sure.
Here we have a question. Probiotics don't colonize the gut, ? This is new to me. Can you elaborate?
Yeah, so probiotics are not commensal. They're not microbes that typically reside. Well, that's not true. Some probiotics are commensal, but very few exist that are. So commensal means like actually existing in the human gut, colonizing the gut. So the particular strains of them tends to be microbes that are more like tourists. They come in, they do a specific job, and then they leave. In addition, our microbiome is very established, so it's not like a little visitor can come in and push other microbes out of the way and then colonize the gut. So probiotics are transient in nature. They enter the gut, they do a specific job, and then they leave. Most probiotics don't persist in the gut for more than 2 to 4 weeks. There is one study that's looked at disruption of the microbiome with probiotics post-antibiotic use. It was with a specific product, And it didn't look at colonization. It actually looked at how the microbiome was disrupted by antibiotics and how long it took for that microbiome to get back to baseline, the person's baseline. And the study found that that particular probiotic actually slowed the process of the microbiome recovering to that person's baseline. And I think sometimes people think just like at a glance that study is referring to colonization, but it's not. It's referring to the disruption of the microbiome recovering to baseline.
Thank you, guys. Here we have another question. Any thoughts on increasing polyols or sugar alcohols to help with laxation for constipation?
Yeah,
I love
that's
that for chronic constipation. Yeah,
sorry, I'm jumping in on your
No.
topic there, but I will say, like, I use this in practice sometimes, not too often if there's a lot of gas as well, but like that's the mechanism of prunes, or part of the mechanism of prunes, and some of those like pitted fruit. So, it works, and there's lots of different studies and anecdotal evidence as well with fruit like that. So yeah, for sure. Do you want to add to that, Andrea?
Yeah, absolutely. I don't have too much to add, but it can be a really helpful tool in our toolkit for constipation management to utilize those polyols. In that comparator study of prunes, kiwi fruit, and psyllium, because of that osmotic pull, it contributes to more of a sensation of bloating, the prunes specifically, than looking at the kiwi fruit. The participants in that study actually preferred the kiwi fruit over the prunes. But I also find patients really do like prunes for constipation management if they're not as like viscerally hypersensitive as your IBS patient.
Great. And then continuing on this theme of constipation, Emily asked, how do you estimate their fecal load?
Yeah, so I just wrote a book, guys.
It's
and
excellent.
Marlee, I think actually Marlee and I wrote a book, I should say that. So fecal load, this isn't a validated tool, but assessing how frequently they have stool, the volume of stool, what else do we do in that little quiz? Frequency of stool, volume stool, stool consistency can be really helpful. The best way to assess fecal load is an X-ray. But we do have a little quiz in this book to help. Again, it's not validated, but we've, used it and feel like it's a pretty helpful tool, and thinking like, okay, do we need to clean this person out in absence of an abdominal X-ray, which can be hard sometimes to get buy-in from a physician. It's not very invasive. It's not a ton of radiation, and it can give us a good picture to get an X-ray, but you can't win them all when making recommendations. But typically you do an X-ray, you draw an X like this over the colon, and then the radiologist would rate the fecal load out of 12. You'd get, 3 points for each section based on how much feces is seen in the colon.
Great, thank you guys. And here, this will be our last question. We've got one from Alexis asking, any recommendations for someone with microscopic colitis who has diarrhea only in a flare and otherwise just struggles with constipation at baseline?
Yes. So I would treat the two scenarios separately. I'd focus on constipation management first and probably more heavily lean towards fiber supplements, which is like a great regulator. It can bring diarrhea in, it can bring constipation in to the kind of middle where patients want to be. And then I'd have a patient start tracking what kind of goes on during a flare. I'd probably work with their gastroenterologist. A lot of my patients do keep budesonide on hand, have a filled prescription for when they do have a flare. And then they have a plan with their gastroenterologist. Do I jump right up to the 9 milligrams a day? Do I start at 3? It depends on the history of their flares, how quickly they onset, and how severe it is. And of course, gastroenterologist preference. But I'd probably focus on constipation management, really get that under control, and utilize fiber supplements. so that if diarrhea flares, at least you're getting that water binding effect.
Mhm.
Great, very helpful. Well, that concludes our webinar today. Thank you both for sharing your expertise